So my name's Alex. I'm one of the organ donation coordinators here at Donor Connect. So today I'll just be sharing about donation after circulatory death. We're going to talk about the history of where DCD came from, where it started, all the discussions that were surrounding it, and then how we can use all of that discussions that were had in our future endeavors with transplant and donation. So the DCD, or donation after circulatory, or cardiac death, you'll hear it used interchangeably, is defined by the National Health Service as the procurement of organs for the purpose of transplantation from patients whose death is diagnosed and confirmed using cardiorespiratory criteria. So essentially what that means is it's a patient who is able to donate their organs when they are not declared brain dead. So we're extubating them in the ICU or the OR, they're allowed to pass, and then they're declared deceased by listening to heart and lung tones where they're no longer having a heartbeat or respiratory function, and then at that point we can proceed with donation, as opposed to our brain dead donors who go to the OR on the ventilator with their heart still beating. So why DCD? As you can see here, these are our data points for DCD and brain dead donors going back about 2018. The column on the left you can see is all of our brain dead donors per year, and the column on the right is our DCD donors. As you can see, up until 2023, our brain dead donor potential was basically the same. It was about 89 to 92 donors a year, and even going back previous years that this graph doesn't show, that was about the same. So our brain dead potential is relatively maxed out. We're not getting any more. The one interesting fact that we saw was in 2023, our latest year, is our brain dead donors actually went up for the first time in a long time, and we had a decrease in our DCD donors. Our current theory on that is the advent of transmedics, NRP, Paragonics, all these new procurement and perfusion technologies allowed us to pursue more patients, as well as we spent longer in the ICU working up these patients, matching our DMGs, that more patients that would have normally moved to comfort measures or gone the DCD route actually ended up progressing to brain death. So we'll kind of keep the trend on that and see if that continues in that, or if we just go back to normal, and that was an odd year. So we're going to take a step back and go into the history of transplantation and DCD. So the first kidney transplant was done by Dr. Hume in 1951. Our first liver transplant was done by Starles in 1963. And then the first heart transplant was done in 1967. However, the first talk of irreversible coma brain death was actually done not until 1968 with the Harvard Committee, and it was their ad hoc that they got together. And it was the first mention that anybody had put together of any sort of irreversible coma. This was further expanded upon and researched in the 1970s when brain death criteria became a lot more formalized. It became recognized by various medical associations, and that's really when we started diagnosing patients as brain dead. And then we actually began to reevaluate DCD back in the 1990s, but we started organ donation and transplantation with DCD patients because brain death didn't exist when we were starting transplantation and donation, and up until in the 70s we were still transplanting and doing donation on patients who were basically DCD because brain death didn't exist yet. We hadn't recognized it as a condition that patients could reach. So then there was the big conference in the 1990s where we actually reestablished DCD as a actual way to procure from patients because up until that point we had just been solely removing and pursuing brain dead patients. DCD patients were not considered in the 90s and 80s once brain death had been established. So, like I said, they held the first conference in Philadelphia in the early 1990s, and they ended up developing what's called the Pittsburgh criteria. It was by Michael DeVita and James Snyder were the main proponents and authors of this. And the Pittsburgh criteria established the first DCD donation policies. It was the first sort of look and taking a way to establish DCD, to make it uniform across the country. So we'd had these many years for brain death. That was established with the Harvard Committee and further in the 1970s. So this was a goal to do that same thing for DCD. This conference, this Pittsburgh conference, everyone that attended published numerous articles about the ethics behind DCD, the logistics behind DCD. Was DCD a way that was safe for recipients and donors to move forward with donation? And all of these got published in the Kennedy Institute of Ethics Journal. That was a special release or special issue in '93. And that was titled The Ethical, Psychosocial, and Public Policy Implications of Procuring Organs from Non-Heart-Beating Cadavers. So again, this was really the first time that the organ donation and transplant community had really come together to take a look at DCD seriously. And this conference was the first one where they really started looking at the ethics behind it, trying to define when patients had passed, looking at the principle of permanence in donors and their passing as far as, resuscitation measures had come a long way. So again, this was really the first time we looked at that. There was a lot of controversy with DCD at this point. As you can see in the center, this was a 60 Minutes piece titled "Not Quite Dead." There's numerous articles. Some of those headlines are small to read, but there was one on the top left, "Clinic Puts Hold on Controversial Plan for Transplant." That was out of Cleveland, and the hospital in Cleveland had planned to do a DCD cardiac donor. The coroner was notified about this, and the coroner went into the newspaper saying if they move forward with this, the medical team would be put in prison for attempted homicide. So there's a big deal about DCD at this point. There was a lot of strong feelings in the public. There was a lot of public controversy. And even up until about 2007, that article from the Los Angeles Times was published in 2007, still having people feeling very uneasy about DCD patients, about pursuing donation in this. So at that point in 1997, with all of this controversy, with these conferences that are being held, with all of these discussions about ethics, the Department of Health and Human Services went to the Institute of Medicine and said, we need to look at this officially. We need to establish our policies. Is this something that we can continue moving forward with, or is this something we need to not do anymore? They published 2 reports. The first one was in 97, you can see it on the left, and this was Non-Heart-Beating Organ Transplantation Medical Ethics Issued in Procurement. So this looked really at the ethics. They got a lot of ethics committees together, and they looked at just the ethics behind DCD donation. They looked at it all fronts, from the transplant center side, the donors, the donor families, as well as the recipients. And they looked at all of this information. Based on that report, they got another group together, and in 1999, they released their second report, which is Non-Heart-Beating Organ Transplantation Practices and Protocols. What this second report did is it formally outlined DCD as a method of transplantation and donation that is ethical, it is acceptable, and here's the principles and policies that OPOs and transplant centers should begin to adhere to create their programs. The biggest thing that came out of that was this second report said in no uncertain terms, all organ procurement organizations, OPOs, should explore the option of non-heart-beating organ transplantation in cooperation with local hospitals, healthcare professionals, and communities. So this was the first time, and this is the Institute of Medicine saying DCD is something we should pursue as far as OPOs, hospitals, as well as the community partners. This is something that is ethical, it is something that falls within the standards of transplantation and donation, and this is something we should move forward in. And then again, after this report published, more and more centers and people kept going back to reevaluate DCD. Again, reestablishing that, was this report correct? Were there things that they had missed? And there just was continuing support for DCD. So in 2001, the American College of Critical Care Medicine and the Society of Critical Care published their position paper on recommendations for non-heart-beating organ donors. And essentially what they came out and said is, us as the American College of Critical Care Medicine, the Society of Critical Care, we are in favor of DCD donation. It is something that we will stand behind, and we feel that it should be something that moves forward in the donation and transplant communities. And then in 2003, the University of Wisconsin published a paper on what is called their Wisconsin tool. And it was the first look at evaluation of DCD donors, because DC donors, they're not brain dead. So we have to have the thought process of, will this patient pass in time for donation? And the University of Wisconsin released their tool that they had developed, and it was really the first time that they looked at establishing guidelines for how OPOs should evaluate potential donors in DCDs. We use a very similar tool. It's been modified over the years as we found more data and research, but this was really the first time that anyone had something like this. And then in 2004, the University of Wisconsin also published in the Annals of Transplantation the Donation After Cardiac Death, the University of Wisconsin Experience. So during this whole time, this early 90s, where we're having all these discussions, there's this huge public controversy. The University of Wisconsin had continued with DCD. They had, once they had started, they did not stop. They were keeping their ear to the ground and seeing all of the studies, ethics, what have you, that were coming out at the time, but they had not shut down their DCD program. They were still pursuing DCD donors. And they published their findings. How did it go? What was their outcome successes? What did they find? Problems? They published all of this information in this first paper. And it was really the first time that a transplant center had come out and said, here's our experience with DCD. Here's what we have found. And then in 2005, Frank Delmonico held the second Pittsburgh conference. And that was really kind of the final point after all of these letters of support, the IOM investigations that said that DCD is ethical, acceptable practice in the end-of-life care and can increase the number of donors. And they published their report in the the American Journal of Transplantation. Is essentially a summation of this conference that said that the American medical community as a whole will stand behind DCD donation and that we have found it is ethical in end-of-life care for donor patients and their families. And so this I found to be a really interesting graph. This was from a presentation given by the Gift of Life OPO, and this shows the number of DCD recoveries done in US states per year. So you can see in 1995, all of those red states have never had a DCD donor at that point. All the blue states have. So you can see back in the Northeast and up Wisconsin and Ohio, where they had all of these ones, they had done DCDs in 95. Then you can see in 2004, there was quite a large amount of states that had pursued at least one DCD. And as you can see, us in Donor Connect, we still had not done one at that point. But by 2018, every state in the United States, besides Puerto Rico, has had at least one DCD patient since then. And so as you can see, as these conferences and as these papers and these investigations are coming out, more and more states, hospitals, OPOs, and transplant centers have accepted that DCD is something that we can safely, ethically pursue while still maintaining good outcomes for our transplant patients as well as our donor patients and their families. This one is also a pretty enlightening graph for what I feel is you can see this is all the numbers of organ donors in the United States from 1995 to 2022. The light blue is brain dead donors, and on the yellow one, those are DCD donors. As you can see in 1995, there was about 5,200 or so brain dead donors, and there was 65 DCD donors in that year. By the time we get to 2022, the number of DCD donors nearly exceeds the amount of brain dead donors that we had in 1995 at about 5,000, or close to about 5,000, while we had almost over 10,000 brain dead donors. So this really goes to show that the advent of DCD has just continued to evolve. And you can see in the last 3 years, there's quite a large jump of the number of DCD donors, and that's right about the time that technologies such as transmedics and NRP really started to become more widespread adopted in the US, as well as just OPOs were continuing to improve in their DCD management, allowing more patients to qualify as donors, as well as allowing more organs to be safely transplanted. And currently, as of 2022, about 32% of all donors in the US are DCD. At Donor Connect, I have our metrics. So these are all the OPOs in the United States. And this is as of 2021. This is the percentage of their donors that are DCD. As you can see, we're UTOP, Donor Connect. We had 52% DCD donors in 2021. We were the #1 of the country. So as far as we go for DCD rates, DCD outcomes, we are a Tier 1 OPO and we are a Tier 1A. And as you can see, we're the #1 OPO in the country for DCD donation rates. So that's pretty huge for us, especially given our area, and then the fact that we have been pursuing NRP with our OPO and local transplant centers. So we've talked about the history. Where does that put us now? How are we going to use the lessons that we learned, and why did I just tell you all the history of DCD? Well, with NRP and transmedics, it's currently undergoing those same discussions, those ethics discussions. It's undergoing those, in principle, does this work? Is it safe? Is it ethical? Can we still maintain the safe principles of dignity and dying with our donor patients? Are we adhering to ethics, legal, all of those? It's having that same discussion with one huge difference. We are not seeing nearly as much public coverage of NRP in such a aggressively negative light. We are not seeing an article on 60 Minutes titled "Not Yet Dead." We are not seeing headlines in the Los Angeles Times saying that hospitals are removing organs from live patients. That's just not happening because the medical community as a whole has said, this is still DCD. NRP is still DCD at its heart. So the big thing that we want to ask of our colleagues and our hospital partners is, when we're talking about NRP, we should have these discussions. Any new technology that comes to our aid to transplant, we should talk about this. But There's 30 years of precedent and discussion surrounding DCD, so we should not go back to square one when NRP is involved. It is still DCD. We should talk about how it is involved, but use all of the data and principles and everything we've developed and standard of practice for 30 years. We should build on that. We should not start over from square one. And there's already articles being published and put out in support of NRP. This is one from a team in the UK, and this is them putting out their proposal utilizing NRP in DCD patients. And that was published in 2019. So we are already seeing that we've had, we're getting to the point that we're starting to see organizations give their support of NRP, give their support that's saying this is ethical, this adheres to the principle of being dignified for the donors, and that this is not something that is going to harm them in any way if it is done properly. So we're already starting to see, and then on top of, we're starting to see the data come out of how beneficial NRP can be for the donors, for their recipients. And as you can see in the earlier slides, we're able to massively increase the number of donors in DCD. Like I said, we have almost surpassed the number of DCD donors that we had total donors in '95. And that can only do good for our transplant recipients, because as Carrie showed, there's over 100,000 people waiting, and 16 people die a day. So if we can transplant just one more, that's one more life saved, and that's ultimately our mission in healthcare, is to save and improve lives.